So what I'm going to speak today is about some issues related to gallbladder cancer and the precursor lesions for that disease. First, I'm going to, in my disclosure, I have nothing to disclose for financial interest. This is the outline of the talk. We're going to talk first about how did we get to know this disease a little bit better. Then we're going to talk about the precursor lesions and the definition of some of those lesions, which I think is much better now. Some controversies in the management and diagnosis of T1 and 2 lesions. And finally, some comments about pancreatobiliary maljunction. How did we start here? So, 2008, I received a visit from a surgeon from Chile. He came here to spend 6 months. He wanted to train and do liver surgery in Temuco from the Universidad de la Frontera. And what in my conversation with him, and it was not well known to me at the time, he was telling me how the incidence of gallbladder cancer in Chile was the highest in the world, no questions. Second, Korea, and third, probably Japan. And he showed me this slide that showed that in cancer-related deaths in women in Chile, gallbladder cancer accounts for 15 out of 100,000 people. That means this is the highest mortality on women, even above cervical cancer, breast cancer, gastric cancer, which Chile is well known for. So this actually is something really remarkable. For those who are interested in geography, this is South America, this is where I'm from, and Chile is this strip of land that comes all the way in the south of the continent. Not every region in Chile has such a high incidence of gallbladder cancer. In fact, the north part is almost as equal as the rest of the world. However, and you see here showing in red color, right in the middle, the chance of mortality for gallbladder cancer is increased in a 26-fold. This area right here has an extremely high cancer-related mortality for gallbladder neoplasia. And that's where Temuco is, and that's where this surgeon was from. And there's some explanation. This is really fascinating. So there is a Native American population right there in Temuco. They don't go anywhere. They don't marry anybody else, so it is an inbred population. And if we remember, the highest incidence of gallbladder cancer in the United States is in New Mexico in the Native American population as well. So there should be some genetic predisposition for that. The incidence of gallstone in this area is extremely, extremely high. And something else that really caught my attention, there's been a high prevalence of typhoid fever in that area, and you can see here from the 60s. And 5% of the patients after typhoid fever become asymptomatic carrier, having the Salmonella typhi in the gallbladder, producing chronic inflammation over the years. And they think that this incidence of rising gallbladder cancer is related to this prevalence of typhoid fever in that area. And then with time, there was an outbreak of typhoid fever here in 1975 that lasted for 15 years. So according to the epidemiologists, the gallbladder cancer incidence in that area is going to rise even higher. So when we knew all this, we decided to pay a visit to this area because we thought it was going to be a really big source of interactive knowledge. So Dr. Volkanadze, who's been really the leader on this collaboration, he's the chief of pathology at Emory. And I went down there and spent a couple of weeks. We've been there after that first visit. And he sat down with pathology, go over the slides, and I went to the OR. So we really created a very nice environment where we kept in straight communication. The issue here is that the staging of gallbladder cancer, as I'm going to show you, is not very well defined. And this collaboration with Volkan has been really critical to develop that. The other thing is, if you read up to this point, the series on patients with gallbladder cancer is minimal. They come from they're a small series from one institution, so you just don't get good number to make really good contributions. And most importantly, since they have recognized this as a public health problem, they have created a long-term survival data on these patients. So it was really good. So this was the first paper that we collaborated with. This is a paper we published in the Journal of Gastrointestinal Surgery. And we wanted to see if the patient had any imaging or any radiology, there was any suspicion of preoperative cancer, how did they behave compared to the patients who did not have that, in whom we did suspect gallbladder cancer. And we were able to collaborate with Dana Gordon at Mayo and the series from Temuco and our own series from Emory. We were able to round up 570 patients. And this is the Kaplan-Meier curve for this series. We noticed that in patients in whom we did not suspect gallbladder cancer, the survival was significantly better. So any astute clinician is going to say, obviously, see, if you don't suspect, probably you don't have a mass, so this probably is an early tumor. In fact, we control for the pathologic T1 lesions, and that difference remained. And when we analyze separately the T2 and the T2 lesions, that difference remain. So this is not just related to the depth of the lesion. This is not related because we also did analysis just in the Chilean population or just in the US population, and the difference remained. So at the end, we did a multivariate analysis on this group of people, and obviously a T stage has a lot to do with an increased chance for mortality. But as you can see here, if we preoperatively suspected that the patient had gallbladder cancer, the odds ratio was almost 5. So that was really put us in good shape to start our conversation with our Chilean colleagues. The second point has to do with precursor lesions in gallbladder cancer. And there is a big differentiation between those lesions that form tumors and those lesions that are flat. And the classical description is that tumoral precursors, for us who also work on the pancreas, they are like IPMN. They follow the carcinoma sequence, and these patients, they almost never had gallstones. Whereas you have the flat lesions, the one that not produce tumors, they are more like the panning, like the intraneoplasia of the pancreatic cancer. This goes into developing the typical gallbladder cancer, and these are related to gallstones. So let's talk about these tumoral precursors. This is a typical one of those where you see a big lesion here. However, you see nice demarcation, the smooth contour and all that. You see this MRI. I'm sure this is gallbladder cancer, but is this as aggressive as the typical typical gallbladder cancer where you see infiltration of the liver? Probably not. And this is the specimen from pathology where you can see that even though it's a big tumor, the gallbladder is almost not involved by the tumor. We went back to pathology, and the Armed Forces Institute of Pathology had classified this lesion in 8 one of those. And it's incredible because you go there and look, and they give you this report, and you just don't know what to do with that. And to make things easier, the World Health Organization in 2010 said we're going to have just 2 classifications, one adenoma and one the new term, intracystic papillary neoplasm. Well, Volkan made a twist, and he said, if we're going to make that classification, we're still going to find problems defining adenoma, defining the ICPN. So any lesion more than 1 centimeter, he decided to study it as ICPN. And the 1 centimeter is an arbitrary limit, but it has to do with all surgeons, because typically if the patient had a lesion an adenoma or a polyp less than 1 centimeter, we don't do anything. But if we have a more than 1 centimeter, we offer resection to those patients. So by taking all this data, he made this definition. The ICPN, which has to do with intramucosal lesion, and you can see here, forming a mass more than 1 centimeter, and you can distinguish completely from the surrounding mucosa. So that's ICPN. And in these patients, after treatment, what he found was this, and it was published in 2012. If you have an ICPN, with no invasion of the tumor, this is your prognosis, much better than if you have ICPN with tumoral invasion. So this is very, very clear. It creates a nice differentiation. But the most important part here is if you compare this curve to the patient with ordinary gallbladder cancer, the prognosis is significantly better. The biology of these tumors is significantly better, sort of like we think on IPMN on the pancreas versus typical pancreatic cancer. So you guys may be thinking out there, if the patient has an ICPN and no invasion, how come you have so many deaths here in the first year? The problem there is most likely they have missed the invasion of the tumor. The sampling has been inadequate. It's just through the lesion, and some invasive component has been missed, and because of this, we think there is a drop in the mortality in the first year because there's not much of that. The other drop of the mortality on the survival, comes here, and these are patients that we see that 8 or 10 years after this diagnosis, especially if they have a lot of high-grade dysplasia in the gallbladder, they have this field defect, and these patients will come back with bile duct cancer. So again, you remove a lesion like this is an ICPN, no invasion, you're still not happy, because if you ask if there's high-grade dysplasia in the rest of the mucosa, these are the patients who have a field defect, and they're gonna go and develop bile duct cancer. In this population, once you rule out the first year where you miss the invasion, you can see that the biology of this tumor is completely different, and this is the importance. This patient probably had a very good analysis of the gallbladder and histology that I'm going to describe in a second. But because of that, we can see this big difference. And same here, where we see, even though you have an ICPN with invasion, the prognosis is much better than the ordinary gallbladder cancer. So the issues here, and you go to pathology, and they open the specimen, and if they see this lesion, and they have a small stalk, they're probably going to think that there's some debris, and there's a granular component, they just throw it away, and they have thrown the big lesion. Because of that, I think it's critical that we are present when they open these gallbladder specimens and account for every single lesion there. Not only that, demand this. This is the way Emory now does gallbladder processing. They submit the entire organ. They open the organ longitudinally, and they cut 3 by 0.5 centimeters, and they submit it completely, because this is the only way they can tell you there is invasive or there is no invasive component. Again, the most important part is to rule out invasive carcinoma, but in those patients that I just showed, 55% of them had invasive cancer. So this is important, because if you just go through the lesion, you don't see invasive component there, you're not done. They have to submit not only the entire lesion, but also the surrounding parenchyma. Now, let's talk a little bit about the non-tumoral precursors, the fly lesions. So they just come as a low or high-grade dysplasia, which basically is the same as carcinoma in situ. Also, the WHO once prefers to be named high-grade dysplasia. They have the typical progression to gallbladder cancer, and the mean age of diagnosis for dysplasia is 57 years, compared to invasive cancer, which is 66 years, which shows you there is an evolution from one to the other. And, but the other problem here is that sometimes this is impossible to recognize macroscopically. Went back to Chile, and this is a series of more than 1,300 gallbladder cancers in over 20 years. In the pathologist, there's no pathology tech there. It's the pathologist who got the specimen. He reported that in 39% of the patients, he did not find any lesion. So the only way to find the lesion was submitting the entire gallbladder for processing. So this was really an eye-opening for me. Let's talk a little bit about controversies on T1 lesions. This is the TNM classification, and we all know that the important part here, T1 and T1B. T1 is the invasive lamina propria, and T1B invades the muscle layer. From there on, the T2 goes into the areolar tissue, and T3 invades either, perforate the serosa or invades the liver. I put the line here because surgeons, we are told that any lesion, T1B or above, T2 or T3, requires a radical resection, meaning subsegmentectomy for find the liver and portal lymphadenectomy. So again, up to T1, simple cholecystectomy, T1B or more, radical cholecystectomy. The problem with TNM is TNM has been adopted from the histology of the GI tract. And in the GI tract, you see a beautiful mucosa here, muscularis mucosa, submucosa, muscularis propria. Then when you go and apply that to gallbladder cancer, the things are not that easy because you see the mucosa here is not very well defined, even though you can see it clearly, but there's some invagination of this mucosa deep into the into the tunica muscularis. There is no muscular mucosa. It just goes all the way to the tunica muscularis. And you see a nice band of muscle tissue here that you don't see on the gallbladder. So that's a big deal. The other thing is, you see the GI tract histology, the T1 in situ, the tumor in situ comes down here to the muscular mucosa. And when you see on the gallbladder, basically in that same space, you're going to have the T1 in situ, the T1A, and the T1B. So you put it hand to hand. It's basically like the T1 lesion. I mean, the T1 and the T1 lesion of the gallbladder is basically the same as the T in situ of the GI tract. You go to the website of the American College of Pathology, you're going to see this graph here. Nice cut. And this is American College of Pathology, and they show you a nice a drawing of how the gallbladder histology looks like, which is completely different than this. You don't see the nice, again, muscle band that you see in the drawing. You don't see it here, and you see these invaginations, and see a lot of lamina propria in between the muscle bands, and that has to have a difference in the behaviors of the tumor. What about if you have a tumor that is invading all the way here, the deep in the mucosa? How do you call that? Would you call that the T1 in situ just because it hasn't perforated, or is already below the muscle? So is that a T1B or a T2? So that criteria needed to be defined. So when they compare, and when you see in the literature, you see that in the East, in Korea, they classify T1 as a T1, 35% of the lesions in the gallbladder. On the SEER database in America, 40% are T1. But when you go to institutions that really work in gallbladder cancer, less than 3% are classified as T1. That means there is a huge difference in the interpretation of these slides. And that makes things really difficult for you to evaluate the treatment of these patients, because if you don't have good staging, you're just not going to have a good correlation with the behavior. Very interesting study done a couple of years ago. Like around 40 pathologists went to Chile, experts from Korea, Japan, Chile, US, and Volkan, what he did, he chose 19 cases where there was no invasion, so in situ lesions, and showed it to everybody. And this is the result. These are percentages. This is C means Chile, K means Korea, J Japan, E Europe. And you can see here that Chileans, for the most part, declared that most of the lesions were invasive carcinoma, when in reality they were in situ. Saying the Koreans, half of the lesions, they declared they were invasive carcinoma, when in reality they were in situ. So it's really a difficult interpretation of the data based on that, because we just don't have the staging that we need. In any event, these are 4 of the largest lesions in specialized institutions, and you can see here that the frequency of T1 lesions goes between 2.9, 0.7, 2.5, and 2.7, so less than 3%. What is the issue with that? So you have an area that is probably 1 millimeter or less. You have subclassified that in 3 stages, in situ, 1A, and 1B. And less than 3% of the lesions correspond to that area. So it's just to make things simpler, this group from Chile, what they did is they took 190 patients and combined T1 in situ, 1A and 1B. And this patient was submitted to simple cholecystectomy. There was no liver resection here. And the 10-year survival, I'm not saying 5, 10-year survival was 90%. I mean, this is including the T1B that classically were taught to do a liver resection. So because of that, they introduced the concept of early gallbladder cancer. So any T1 is an early gallbladder cancer, simple cholecystectomy will suffice. Beyond T1 is advanced gallbladder cancer, you have to do a radical resection. When they did the analysis between the T1 plus carcinoma in situ compared to the T1B, there was no difference. So we think that simple cholecystectomy will suffice, and this is basically a landmark paper done in combination with the Chilean group and Volkanadze. So then where this theory of that you have to remove, do a radical resection on patients with T1B. These are 2 landmark papers, review papers, and this is verbatim from the paper. In case of T1B tumor, there have been reports of recurrence and death after simple cholecystectomy. Principi and colleagues reported only 50% 1-5-year survival with simple cholecystectomy. Therefore, you may have to do a more radical operation if the patient is fit. So 50% 1-year survival per principle. But you go to that paper, and you find things that are different. In reality, in that paper, there are just 2 patients with T1B. They're right here. The 1B that they are interpreting is actually a stage on their AJCC 2002. So I think there is a misinterpretation of this data by claiming that only 50% of the patients were alive at 5 years and at 1 year. I think this has created a lot of confusion, and based on the data that I've shown you, I think, and based on this, I don't think there is any justification to do more than a simple cholecystectomy for a T1B lesion. And in those series, basically there is only 1 patient, that patient that I just mentioned, death of disease, including the other 3 bigger lesions from the West. A word on Rokitansky-Ashov. For those, all the people who are not familiar with this Rokitansky-Ashov, some invagination of the mucosa all the way down to the either tunica muscularis or beyond. Those are called Rokitansky-Ashov sinuses. If, and this is, again, going back to that paper published in 2013, if there is involvement of the Rokitansky-Ashov nodes, if there is carcinoma there, the prognosis is significantly lower. And this not only accounts for the early gallbladder cancer in situ 1A and 1B, but also if you go and analyze separately the in situ and 1A, the difference still persists. So if you have invasion of the Rokitansky-Ashov, that's bad prognosis, you have to change your management. So in summary, in T1 lesions, there are major geographic variations on criteria for T1, for T in situ and 1 and B. Among continents, and there is a high proportion of T1, T in situ lesions in the US. A high proportion of these lesions are labeled as T1 and T2 in South America and Asia. True T1 is really rare, it's less than 3%. And that's why it's important having a small number of patients just to create one category, like the early gallbladder cancer, including T1B on that. It makes it easier for everybody. And at the end, the survival is going to be really good after 5 or 10 years. Obviously, that's provided that the whole specimen has been submitted for evaluation and T2 carcinoma has been ruled out. So simple cholecystectomy is the choice for these lesions, except if there is a Rokitansky-Aschoff sinus invasion. Let's talk about a little bit about T2 lesions. So that's the most frequent T stage in gallbladder cancer. A large proportion of these patients still won't have any suspicion of my microscopic evaluation of the tumor, and typically, and this is according to SEER data, which is not the best, the 5-year survival is 30%. So to know more a little bit about this lesion, there was a collaboration with Chile, USA, Korea, Japan, and Turkey, and again, Volkan is leading this effort. They evaluated 326 patients and found that the 5-year survival for this population, T2 lesions, is 50%. Not as bad as the SEER has said, and not as good as the Korea has said. But are all the T2 lesions equal? So if you imagine here in the T1, for that less than 1 millimeter or millimeter of tissue, there are 3 subclassifications. And for the T2, which is basically the majority of the patients, and big chunk of tissue, there's just only 1 classification. So the analysis was done in subclassifying the T2. So now we make it simpler for the T1. We have to complicate a little bit for the T2. But they classified in levels, 4 levels, and the first one was just penetration beyond the muscularis, still in this fibrous, dense tissue. T2B a little bit deeper, and C and D, or 3 and 4, level 3 and 4, is in the areolar, being 4 the one closest to the serosa or the liver. And in this classification, these 326 patients actually paid off because the T2A has a significantly better prognosis than the T2D, even though all of them were T2. The important thing is that the 5-year survival for a T2A is 90%. And this not only is important for the T2 lesions, it's also important for the T1. Remember when I told you about the T1B having a 5-year survival of 90%? Well, this graph on T2A gives more credibility to the fact that the T1B lesions are not as bad as were portrayed at some point, and the survival still is much better. Level 4, again, has a poor prognosis and is basically the same prognosis as a T3. The people from Korea who did not participate in this, they came to America, actually. They looked at the slides with our group, and they tried to classify in the same categories, but the numbers were not that great, so they combined T2A, or level 1 and 2, versus level 3 and 4, and they found a huge difference too. So this is probably has to do now with the way we're gonna classify this lesion and the way we're gonna treat them. Finally, a word about pancreatobiliary maljunction. So this is the normal junction of the bile duct. They come into the duodenal wall, and we have a sphincter surrounding both of them. The sphincter surrounds the bile duct here, the sphincter surrounds the pancreatic duct. There is no set number to say that there is pancreatobiliary maljunction. All we need to say, and we can see that on the MRI, on an ERCP, is that the level of the sphincter is below the junction between the pancreatic duct and the bile duct. Why is that important? We know that the pressure inside the pancreatic duct is higher than the pressure inside the bile duct. So it's natural that when this sphincter contracts, the pancreatic juice is going to reflux into the bile duct. And that's real. Not only will go into the bile duct, will also go into the gallbladder. And this is known because sampling from this fluid in the gallbladder in these patients has shown that the fluid is very rich in amylase and lipase. And that has really important things for the future. The phospholipase that is contained in the gallbladder, in the pancreatic juice that is normally present in the gallbladder, combined with the bile and form lecithin that will break into free fatty acid and lysolecithin, which is a very cytotoxic agent. And this is the basis for all this cascade that has been tried to explain in patients in whom you have pancreatic biliary malfunction and go and develop pancreatic cancer. It's a well-known fact that in these patients, when they do markers like P53 and KRAS, they contain these markers that are not present in normal gallbladders. Not only that, you can have two presentations for the gallbladder damage, one with the normal bile duct, you can see it here, or one with the dilated bile duct. But what I'm trying to call the attention is the anechoic part of the mucosa, how thick that is in some patients with pancreatobiliary malfunction. That's something that really needs to be looked at, because I don't need to be a pathologist to know that there is a huge hyperplasia on the mucosa of this in here, and this corresponds to a patient with pancreatobiliary malfunction and no gallbladder cancer, just pancreatobiliary malfunction. And that's been studied not only in the US, but also in Japan. You see that the height of the mucosa in the gallbladder is significantly lower than the height of the mucosa in pancreatobiliary malfunction, independently of having cancer or not. So that's a new concept now. It's called hyperplasia, dysplasia, adenocarcinoma. In the 80s, the Japanese identified this, and they created a group called the Japanese Study Group for Pancreatobiliary Malfunction. And since the 80s, they have created a database, and they've been following these patients over years. And this is a little bit eye-opening for me. They follow almost 2,000 patients with pancreatobiliary malfunction and dilatation of the bile duct, and they claim that there is a 21% chance of developing biliary tract cancer. And most of them, that is shown here, 60% of them are gallbladder cancer. That number is huge, 21%. Now, if you have pancreatobiliary malfunction and there is no dilatation on the bile duct, the chance of developing biliary tract cancer is even higher, 42%, with 90% of them on the gallbladder. It's really, for me, this incidence is extremely high, and only the fact that there are not many patients with pancreatobiliary malfunction tells me that we're not seeing more of these patients, but these numbers are huge. If we consider that the incidence of PBM in general population is less than 1%, the incidence of PBM in gallbladder cancer, you see in different series from Japan and Korea, is around 8 to 10%. So we at Emory, we went and looked the last 50 cases of gallbladder cancer where we can find an MRI or an ERCP or something that could tell us if the patient had pancreatobiliary malfunction. And we used patients in 1 year that went for laparoscopic cholecystectomy just for cholecystitis. So of the 66 patients, none of them had pancreatobiliary malfunction. But on the patients from the 50 that had gallbladder cancer, we found pancreatobiliary malfunction in 7, which is 14%, kind of close to what I have described here. So this is a reality. When you think that there is less than 1% of the patient will have that, and in patients with cancer, you're going to have 14% or 10% or 12%. I think there is something there. So the recommendation for the treatment of these patients in Asia, mostly Japan, every patient with pancreatobiliary malfunction will get a prophylactic cholecystectomy. I understand this number that I just presented from the Japanese data, they're really strong. So in the US, if you're not convinced by these numbers, if you do an ultrasound of the patient, you see normal gallbladder mucosa, surveillance is the way to go, and then you can do surveillance with ultrasound. But if you see that thickened gallbladder mucosa, I think cholecystectomy is justified. Now, if you have also dilated bile duct, the recurrent recommendation is to do excision of the bile duct and hepatocytostomy. Thank you very much.